Sharita, clinical physiology. This month's Clinical Corner presentation is on Copiktra, Duvelisib for relapsed or refractory CLL, SLL. Sharita.
Thanks, Stephen, and thanks, Encoda, for having me this afternoon. We have a lot of information to cover, so we'll get started. First, I want to start by giving an overview of chronic lymphocytic leukemia and small lymphocytic lymphoma. According to the American Cancer Society, CLL is the most common form of leukemia in the Western world among adults. In 2019, they're estimating that there will be almost 21,000 new cases of CLL and almost 4,000 deaths from the disease. So when we talk about CLL and SLL, we're actually referring to the same disease and just differentiating where the disease is located. Both diseases are characterized by an increased number of lymphocytes, and these lymphocytes are non-functioning. These patients commonly develop complications, including infection, anemia, and thrombocytopenia. In SLL, the ineffective lymphocytes are present mainly in the bone marrow and lymphoid tissue, whereas in CLL, the lymphocytes are also present in the blood as well as the bone marrow and lymphoid tissue. Next slide. So, just like with any other cancers, when a patient presents to the practice with CLL, we can determine their prognosis based on a multitude of factors, including the stage, the patient's age, their general health, and response to prior treatment. With CLL, we actually look at some other factors, including IGHV status, whether or not the patients have 11q or 17p deletions, and we tailor their treatment to some of these abnormalities. So the above chart just summarizes some of the cytogenetic abnormalities we look at to determine the prognosis of CLL. Next slide. So traditionally, when we would treat CLL, we actually used a lot of alkylating agents and purine analogs, but that used to be the frontline therapy for CLL, but now we're starting to see that the NCCN is recommending several oral agents, either as monotherapy or in combination with a monoclonal antibody. For example, ibrutinib or Imbruvica is recommended for the treatment of, it's actually a preferred first-line treatment agent for CLL in patients with or without a 17p deletion. And for relapsed refractory disease, we actually see several oral agents, including Imbruvica, Copiktra, Venclexta, and Zydelic, with or without, for patients with or without a 17p deletion, and these medications, either given in monotherapy or with rituximab, can be used to treat these patients. Next slide. So for the Clinical Corner presentation, I want to focus on Copiktra or Duvelisib, which was approved in September of 2018 for relapsed refractory CLL or SLL in patients who have at least received 2 prior therapies. Next slide. So I want to give some general information about Copiktra. It's actually available commercially as a 25 milligram capsule and a 15 milligram capsule. The 25 milligram capsule is used for standard dosing, while the 15 milligram capsules are reserved for dose reductions. The medication is given twice a day, and it can be given with or without food, and there are no dose reduction recommendations for patients with baseline hepatic or renal impairment. The medication comes packaged as a unit dose blister pack with 56 capsules. It contains 2 separate sleeves, and the sleeves contain 28 capsules apiece. Next slide. So how does Copiktra work? Well, it's a PI3 kinase inhibitor, which Andrew touched on earlier, and it works much like the other oral agent, Zydelic. And so what PI3 kinase does is actually part of the intracellular pathway, which helps to regulate the cell cycle. So when you activate PI3 kinase, you activate AKT, which actually has downstream effects of activating mTOR complex 1. So you activate mTOR complex 1 and you have growth and survival of cells, and it actually decreases the cell's natural destructive mechanisms. So when we inhibit PI3 kinase, we actually inhibit mTOR complex, which leads to the suppression of these malignant cells. Next slide. So in the previous slide, I did mention that Copiktra and Zydelic, they work sort of the same way, but Copiktra actually has a slightly different mechanism of action. It does inhibit PI3 kinase, but it inhibits two different isoforms of the PI3 kinase. So it inhibits the delta isoform as well as the gamma isoform. The delta isoform is primarily found in malignant B cells, so when you block this isoform, you reduce the growth and survival of these cells. And the gamma isoform is actually found in T cells and tumor-associated myeloid cells. So when you inhibit the gamma form, you actually reduce the tumor support cells, and it actually enhances the change of macrophages from a more immunosuppressive form to a more anti-tumor form. Next slide. So here are some clinical pearls about Copiktra or associated with Copiktra therapy. Much like Imbruvica and Zidelig, when a patient starts Copiktra, you do see that transient increase in the lymphocyte count. It does not represent disease progression, so keep that in mind. Copiktra also has a black box warning for infection, and the package insert actually recommends PJP and CMV prophylaxis for these patients. There are also warnings for diarrhea, colitis, cutaneous reactions, and pneumonitis based on results of the DUO trial. Unfortunately, for our grapefruit lovers, it is metabolized by CYP3A4, so we have to watch out for significant drug interactions. If a patient is receiving a CYP3A4 inhibitor, you're going to want to reduce the Copiktra dose to 15 milligrams twice a day. If it is given with an inducer, you actually would want to change that medication if appropriate because it could decrease the efficacy of Copiktra. And if you're giving the medication with any CYP3A4 substrates, those medications may have to be dose adjusted as well. So one other thing to note about this medication is that intestinal perforation was not noted with Copiktra therapy. This is a side effect that was seen with Zidelig. Next slide. So Copiktra's 2018 approval for CLL or SLL was actually based on the results of a phase 3 randomized study known as the DUO study. In the study, 319 patients who had received at least one prior therapy were randomized to receive either Copiktra or ofatumumab, given at the standard dose for refractory CLL. The approval of Copiktra was actually based on efficacy and safety analysis of patients with two prior therapies. They determined that the benefit to risk ratio appeared greater in the more heavily pretreated population compared to the overall trial population. In this study, the primary endpoints included progression-free survival, and secondary endpoints included overall response rate, overall survival, and safety measures. Next slide. So I wanted to include this slide in the presentation to show that the trial did include patients with harder to treat disease. Patients were represented who had 17p deletions as well as TP53 mutations and unmutated IGHV. Those patients were also included in this trial. Next slide. So results are shown here. Copiktra actually extended the median progression-free survival for 13.3 months versus 9.9 months for the ofatumumab arm, and this was evaluated by an independent review committee. Patients with the 17p deletion were also shown, which is shown on the chart on the right. These patients also showed a longer progression-free survival with the median PFS of 12.7 months compared to 9 months for the ofatumumab arm. Next slide. These two slides or charts just show that progression-free advantages were also observed across all analyzed patient subgroups. That's shown in the table to the left. The hazard ratio for all groups was less than 1, which favors Copiktra. And as far as secondary endpoints, which are shown in the table to the right, the overall response rate was found to be significantly higher in the Copiktra group, 73.8% versus 45.3% for the ofatumumab arm. And also, patients in the Copiktra group actually had a significant reduction in the lymph node burden, 85% compared to almost 16% with ofatumumab. Next slide. So some common adverse reactions reported during the DUO trial were neutropenia, anemia, diarrhea, pyrexia, nausea, and cough. Some adverse reactions of special interest are listed on the slide. To the right, what we see here is that we have patients who experience rash and pneumonitis, but these patients were often discontinued because of these side effects. But when you see some of the side effects like colitis and diarrhea, there was about 15% of patients who experienced that, but only about a third of them were discontinued from the medication. And for transaminitis and neutropenia, we really didn't have too many discontinuations of Copiktra with patients with those side effects. Next slide. So dose modification and toxicity management strategies are provided in the package insert. For most adverse reactions, Copiktra should be, well, not for most, but for a general rule of thumb is that if a patient experiences a grade 3 reaction or higher, you would want to hold the dose. And if it's a grade 3 reaction, you can restart the dose at 15 milligrams twice a day. If the patient is unable to tolerate this 15 milligram dose, then the patient would need to discontinue. Or if the patient experienced a confirmed case of PJP, the medication would also need to be discontinued as well. Next slide. So here are some, I apologize, for patients unable to afford their medication, the patient assistance programs are available and provided by the manufacturer. There's also a bridge program and a dose exchange program as well. So that just highlights some of that information. Next slide. So in summary, Copiktra is indicated for relapsed refractory CLL and SLL in patients with 2 prior therapies based on evidence from the DUO trial, which showed significant improvement in progression-free survival. The adverse event profile is manageable and is consistent to what was previously seen and observed with other PI3 kinase inhibitors. Thank you. Are there any questions?
Thanks, Sharita. So what we'll do is we'll open up the floor for questions using the chat or Q&A box. Feel free to utilize those functions as well as the raise hand function. And Sharita, early on we did get a question, and the question reads, if a patient is ibrutinib naive and progressed on other therapies in frontline, what clinical factors would you consider in the relapsed refractory setting in choosing Duvelisib over ibrutinib?
So in choosing Imbruvica over Duvelisib, I would actually look at, for the patient's prior therapy, I would take into account the medications that the patient's on, whether or not they have hepatic impairment, since that would be something that would keep us from using Imbruvica. And I would just look at the overall patient presentation to determine whether or not I would use Copiktra versus Imbruvica in that case. There are a lot of different treatment options now for patients who have relapsed or refractory disease. So it would just come down to what would work well for the patient based on just patient-specific factors, drug interactions, and whether or not the patient would be able to tolerate the medication based on how they present it to the practice.
Awesome. Well, thanks, Sharita. If anyone does have any questions, feel free to enter those in the chat or Q&A box below, and we'd be happy to get those questions to Sharita by the end of this webinar. If not, we can always ask your question to Sharita and get back to you as well. So Sharita, thanks again.